I would say, looking at the questions, that some of them were quite difficult. So there's no need to worry about, because difficult questions are difficult for almost all students and they do not necessarily affect the performance and the result. And another thing that I noticed, that there were quite a few number of questions, okay, from the subject of cons and endo. So that is a good part, that these INICET people are giving stress upon these subjects of cons and endo. So good for us. So basically, I would like to reiterate that whatever recall sessions we take for the various examinations, they are based upon the recall sessions from the students and various sources that we collect. At times, some of the questions may not be 100% accurate, even their options may not be 100% accurate. And I would say the language also may be slightly here and there, because they are all based upon memory based recall sessions. But we have done our best to compile and make them as authentic as possible. So I hope it is clearly visible to you all. My screen is clearly visible to you all. And first question, as it is there on the screens, it is asking you about which of the following is true regarding hyperalgesia and allodynia. Hyperalgesia and allodynia. Okay. So these are basically two characteristics whenever there is irreversible symptomatic pulpitis. The patient is suffering from symptomatic irreversible pulpitis. These two features are noticed: hyperalgesia and allodynia. See, allodynia basically means decreased pain threshold. Okay. Decreased pain threshold means, suppose a stimulus of particular intensity is not able to produce pain in a healthy individual. The stimulus of the same intensity would be producing pain in a diseased or affected individual. So the pain threshold of the person is decreased. And hyperalgesia, as the name indicates, hyper means increased response to painful stimulus. If we talk about the quantity of pain, the amount of pain, then the patient would perceive more pain, more severe pain from the same stimulus from which a healthy individual is, I would say, sensing less pain. So hyperalgesia is a response to the stimulus. So the response is exaggerated. The patient feels more pain to a stimulus. What is allodynia? Means decreased pain threshold. The firing threshold of the nerve fibers is decreased, so they start firing and producing pain at a suboptimal stimulus. So look at the options. Cortical plasticity, no. Increased sensitivity of nociceptive afferent nerve fibers, yes, can be a possibility. Decreased sensitivity of nociceptive afferent nerve fibers, no. We know that when the sensitivity is increased, the pain threshold would be decreased. We are talking about pain threshold. So the nerve fibers are more sensitive. They are firing at a suboptimal stimulus. So the pain threshold is decreased and the sensitivity of the nerve fibers is increased. And innocuous stimulus leads to painful response, leads to painful sensation. This is just allodynia. So option B and D are correct in the sense that they are characteristics of these nerve fibers which are affected by allodynia and hyperalgesia. But if we closely examine, this Option B is a generalized statement which is saying that there is increased sensitivity of nociceptive. Nociceptive means pain carrying efferent sensory nerve fibers. Yes. And innocuous stimulus. Innocuous stimulus means a subthreshold stimulus is leading to painful responses, just allodynia. So option B is a better answer as compared to option D. So I would say that definitely there were challenging options to answer. A and C are clearly ruled out. B and D are partially correct, but B is a better option because it is saying that there is increased sensitivity, which is often there. We know that it is there. So option B is a better answer. Coming over to question number 2. What is the diagnosis of mandibular first molar having lingering pain? Lingering pain. Okay, first thing that we notice is lingering pain on thermal stimulus, maybe heat or cold. There is no response to EPT, EOP positive, no symptoms of periodontal disease. Periapical rearfaction is seen in both roots, surrounding mucosa is normal, and there is no draining sinus tract. So numerous conditions are listed. So basically it is talking about a tooth. Suppose this is a tooth. Okay. There is no symptoms of periodontal disease in periapical rearfaction. So the periapical bone is healthy. It is TOP positive. No response to EPT. EPT affects the A delta nerve fibers. Direct stimulation of A delta nerve fibers occurs with EPT. If there is no response to EPT, then the pulp is necrotic. Okay. Lingering pain on thermal stimulus. So necrotic pulp or advanced irreversible pulpitis. Okay. This is the clinical diagnosis we make. So it is TOP positive. There is tenderness on percussion. Tenderness on percussion means there is apical periodontitis. So this is the initial information that we have gathered from the question. Now look at the options. Chronic periapical abscess? No, because this would produce a rarefaction in the root. Rarefaction in the periapical tissues, which is not there. Symptomatic apical periodontitis in irreversible pulpitis tooth. Yes, this can be the answer because there is tenderness on percussion, which means it is symptomatic apical periodontitis, and there is no response to EPT and lingering response to the thermal stimulus, which indicates irreversible pulpitis, pulp necrosis, and symptomatic apical periodontitis. Okay, this can also be the answer over here. And condensing osteitis, no. Okay, now which is a better answer? Symptomatic apical periodontitis with irreversible pulpitis or pulp necrosis and symptomatic apical periodontitis. See, for that we have to look at the options. History again, lingering pain on thermal stimulus. This indicates it is a case of irreversible pulpitis and not pulp necrosis. Okay, so answer B. There is lingering pain on thermal stimulus. Why lingering pain? Maybe it's cold or something. Couple of minutes the pain lasts, and that is characteristic of advanced irreversible pulpitis. Coming over to question number 3. All are true regarding bleaching of endodontically treated teeth. That is, it is asking you about non-vital bleaching. Etching of dentine in the pulp chamber of root canal treated tooth is done. We evaluate the obturation Protective barrier is placed over root canal filling material and obturating material, and rubber dam isolation is done. I think answering this question would not have been a problem, because if we look at the steps that are involved in non-vital bleaching, that is sometimes also called walking bleach or thermocatalytic bleaching. This is the apical katta parcha seal, which is removed 1 millimeter below the CEJ. Then on top of this apical katta parcha seal, we place 2 millimeter thick resin modified glass ionomer cement barrier. The function of this barrier is to prevent the seeping of bleaching substance, bleaching material into the dentinal tubules or in the apical direction. Okay. So rubber dam isolation is definitely done so that only the tooth that is non-vital is treated and is isolated from the adjacent healthy teeth. Protective barrier is placed over root canal filling material is also true. Option D and C are correct. Evaluation of obturation. Definitely before doing bleaching, if the root canal treatment is inadequate, we would correct it. We would do evaluation of the bleaching by radiographic means. We'll first obtain a radiograph of our root canal treated tooth, and only when we are satisfied with the quality of obturation do we proceed with non-vital bleaching. So definitely option B is correct. B, C, D, and correct. Etching of dentine in the pulp chamber of root canal treated tooth is done. No, we do not do any etching. We simply make sodium perborate, which is the agent used for non-vital bleaching, with saline, and the paste is packed inside the pulp chamber, sealed with a temporary from above. Okay. So option A would be the answer. This is not done. Set. Okay. Coming over to question number 4. Mother took tetracycline during gestation or pregnancy, and child has discolored teeth, which is obvious. Which is true regarding the stains? They are congenital stains, they are endogenous intrinsic stains, exogenous intrinsic stains, extrinsic stains. It's a very good question. Okay, tetracycline stains, they are intrinsic stains. We know that, isn't it? They are intrinsic stains because tetracycline is incorporated during calcification of the dental hard tissues, chelated with the dental hard tissues, and gives it a yellowish brown or darker discoloration. So they are definitely intrinsic stains. We would not say that they are congenital stains. Congenital stains are due to conditions like amelogenesis imperfecta, dentinogenesis imperfecta, porphyria, erythroblastosis fetalis, etc. These are the genetic congenital conditions that give rise to congenital stains. So please do not get confused. They are not congenital stains. Although the child is born with discolored teeth, they cannot be classified as congenital stains. Congenital is something that has got a genetic component to it. Here, no genetic component is there. Simply the mother ingested the tetracycline during pregnancy, that went into the bloodstream, and through the placenta, it went into the bloodstream of the fetus. So they are not congenital. I have given you examples of conditions that result in congenital stains. Now, intrinsic stains, both option B and C can be the answer. They are intrinsic stains. Extrinsic stains we rule out. They are not extrinsic stains. Now, endogenous or exogenous. Endogenous means something from inside. Exogenous means from outside. Now, what is happening here? The mother has ingested the tetracycline through the placenta. It has gone into the bloodstream. So they are endogenous intrinsic stains. Answer B would be the option B would be the answer. Exogenous? No. Okay. Exogenous intrinsic stains. Can you think of an example of exogenous intrinsic stains? Means something has been taken up, okay, topically applied, like I would say a person who is in a habit of tobacco chewing for over prolonged periods. Okay, what happens? Some components of the tobacco, they seep through the enamel and dentine and they give rise to intrinsic stain. Primarily, they are extrinsic stains in the initial stages, but when the patient continues with the habit of chewing tobacco, you must have noticed that simple scaling of the teeth, which is a superficial treatment, would not revert the shade to the original, because the shades of an exogenous substance like tobacco, they have pregnated into the dentine of the tooth or the enamel of the tooth. So answer here would be endogenous intrinsic stains. Option B. Question number 5. The modified Iowa index is used for the evaluation of. Now this is a very, I would say this is a new question. Okay. And definitely not expected by majority of the students to answer it. And it is quite difficult also. The modified Iowa index is basically used for the assessment of cracked, that you'll have to remember. It is used for the assessment of cracked teeth. Iowa index. So answer would be option A. Okay. It is used for the assessment of the prognosis of cracked teeth. And what exactly is the Iowa index? If you want, I can let you know about it. So this is what is Iowa index. Okay. This is what the Iowa index is, can be seen over here. It consists of different thick. A first column, you can see it consists of the pocket. CL stands for your crack line. The CL over here stands for crack line. So it basically measures the depth of the pocket in the crack line, and the criteria is 5 millimeter. Either the pockets are shallower than 5 millimeter or they are greater than or equal to 5 millimeters. Then PA status means periapical status. The second column in the pre-op filters you can look up. The periapical status can be normal, or PARL means periapical radiolucent lesion is there. And third thing, the crack line, location of the crack line, that is extension, whether it is involving the DMR. DMR stands for distal marginal ridge or not. So this is a clinical Iowa index based upon the clinical findings after doing excess cavity preparations. We notice the cracks in the teeth of root canal treated teeth may be there. So at the floor of the pulp chamber or at the marginal ridge, we notice a crack. So that crack line is traced, whether it is involving the distal marginal ridge or not. Accordingly, we see the status. And most of the time, these cracks would serve as a pathway for the fluid exchange. So periodontal pocket is likely to occur. For example, we'll talk about a vertical root fracture or crack has occurred. A pocket formation occurs because of fluid leakage. So we would measure the depth of the pocket associated with the fracture line or the crack line, and it can be less than 5 millimeters or greater than equal to 5 millimeters. Similarly, we do the staging into stage 1, 2, 3, and 4. And we talk about the extension of the crack line, whether it is coronal or radicular. So stage 1, 1C and R. C stands for coronal, R stands for radicular. You can take a screenshot of this Iowa index and study it thoroughly if you want to remember it. Okay, so principally 3 factors we consider: the pocket at the crack line, whether the crack line is involving the distal marginal ridge or not, and what is the periapical status of the tooth. Is it normal or there is a periapical radiolucency over there? This is modified Iowa index. to gauge the prognosis of what? Your cracked teeth. Okay. Coming over to question number 6. The patient complains of sudden pain on biting. Sudden pain on biting. Okay. And the provisional diagnosis of cracked tooth is made. Fine. No other endodontic or parodontal finding is there. What are the other diagnostic tests that should be performed to reach a definitive diagnosis? Okay, pain on biting, sudden. When sudden pain appears, means it is not a periapical lesion. It is due to some crack in the tooth that is causing fluid movement and stimulating the nerve fibers. So definitely, we have to look for the tests for cracked teeth. Okay. So what all can be done? OPG, CBCT, staining, and transillumination. 4 options are given, and a combination of these options are the choices for the answer. Okay, then we know that staining and transillumination. Staining with 1% methylene blue dye, and transillumination with a fiber optic light. They are the standard tests for correct teeth. So there should be no problem in option C and D. We look at options A and B. OPG and CBCT. OPG is not a good radiograph for diagnosing a minor defect like crack, which requires advanced diagnostic techniques like CBCT. Definitely CBCT is preferred over OPG. OPG just gives you a gross picture. It wouldn't forget about the crack. At times, it does not even identify a small carious lesion. For that, IOPA is better than OPG. Okay, so the resolution, the diagnostic sensitivity of OPG is very poor. It is just for the gross examination of the dental hard tissues of both the jaws simultaneously. So B, C, and D are the recommended tests for further diagnosis. So we look at the options. Option B, B, C, and D would be the answer over here. Okay. Coming over to question number 7. Okay, the options are missing. But a J-shaped radiolucency of the X-ray, what is the diagnosis? Definitely vertical root fracture. There should be no confusion. It has been taught many times, even there in your class notes over there. A J-shaped radiolucency is pathognomonic for your vertical root fracture. Okay, what is a J-shaped radiolucency? Suppose there is a tooth like this. Okay, it would be having a asymmetrical radiolucency around the root of tooth. This is J-shaped radiolucency, and this is one of the diagnostic criteria characteristic for vertical root fracture. The other options have not been recalled, but whatever may have been the options, VRF would be the definite answer for this question. Coming over to question number 8. The pulp testing for a case of pulp canal obliteration is done by. Now, this is also a very good question. The pulp testing for a case of pulp canal obliteration. What is meant by obliteration? Means calcification. Now, what sensibility test would you use? Carbon dioxide, that is a cold testing method. Ethyl chloride is also a cold testing method. Heat is given there, and electric pulp testing. Now, you should know that the cold testing methods and the heat methods and EPT, all these three are pulp sensibility test. But electric pulp tester causes direct stimulation of A delta fibers. We know that. And these cold and heat cause fiber stimulation. not directly, but by dentinal tubular fluid movement. They caused by dentinal tubular fluid movement. Okay. Now, in the cases of pulp canal obliteration, calcification of the pulp canal. The pulp canal calcification basically starts with the calcification of the dentinal tubules also. Okay. Like you must have known that talked about conditions called sclerotic dentine, isn't it? The deposition of fine calcium crystals like calcium whitlockite occurs inside the dentinal tubules. So these crystals, they definitely restrict the tubular fluid movement. So stimulation by way of cold and heat is unlikely to occur. It would be electric pulp tester that produce sufficient amount of current for direct stimulation of A delta nerve fibers would be the answer over here. Even if you were not able to do that much of rational thinking about this question, you should have looked at the options. Carbon dioxide and ethyl chloride are all both extremely cold agents, negative 41 for ethyl chloride and negative 78 for carbon dioxide. So if two options are there related to cold, there is no logic in choosing one of them as the answers, and heat is definitely one of the least accurate testing method. Heat testing is never indicated as a sole diagnostic test for any clinical condition. That also you can rule out. So option D, by method of exclusion also, you can arrive at electric bulb tester. Question number 9. It is IBQ stands for image based questions. Ellis and Davies classification for arrow marked with I was not able to recall, and some things are given. I do not know what exactly was the figure. The image is not there. This is some sketch, which I do not know is authentic or not. But class 1, 2, 3, and 4 should have been no difficulty in answering this. Okay, this is a tooth. This is the pulp organ of that tooth. Okay, and then there is a enamel cap, CAJ, and dentine over there. This is dentine. This is enamel, cementum over here, and pulp. So class 1 definitely involves enamel, enamel and dentine. Class 3 involving the pulp, and class 4 is a non-vital tooth due to trauma without loss of tooth structure. So whatever the figure would have been there, I think you must have been able to answer it easily. Okay, Ellis and Davies classification. Coming over to question number 10. According to IADT guidelines, 2020 recommended splinting time for delayed replantation is. Now it is basically asking you delayed reimplantation. Do not get confused. It is asking you about avulsion. The tooth has come out of the socket. And what is the recommended splinting time? It is 7 to 10 days of semi-rigid splinting. So 7 to 10 days, 1 week, 2 weeks, 4 weeks, and 2 weeks, 2 months. We rule out 4 weeks and 2 months. So there could have been confusion between the 1 week and 2 week, but 7 to 10 days, it is more than 1 week. So 2 week is the best possible answer for this. With case of avulsion. Whenever there is a case of avulsion with alveolar fracture, the tooth socket is also fractured, there is alveolar fracture, then it is for 6 to 8 weeks. From 7 to 10 days, it would be for 6 to 8 weeks. The splinting is always semi-rigid or physiological splinting that allows certain movement between the tooth and the socket so that no ankylosis of the tooth occurs. Okay. So what would be the answer? Answer would be option B, question number 10. Traumatology is one of the favorite topics for these examinations. Now, this is something that is, I would say, beyond the scope of the UG students, or I would say it is even difficult for a postgraduate MDS student. All those who have done MDS also would find it difficult to answer. This is a purely research based question, maybe lifted from some dissertation or what. The first detectable biomarker in dentinal fluid in irreversible pulpitis. It is basically inflammation of the pulp. Whenever there is inflammation happening, it releases neuropeptides and inflammatory markers, mostly pro-inflammatory cytokines. And if we look at the pro-inflammatory cytokines, they are human necrosis factor alpha, interleukin 1, interleukin 6. The neuropeptides that are released from the sensory nerve fibers of the pulp are CGRP, that is calcitonin gene-related peptide, and substance P. Now, almost all of them are there in the options. CGRP, interleukin 8, substance P, human necrosis factor alpha, and beta defensins 2. Okay. So if I want to arrive at an answer, this is quite challenging because sometimes also matrix metalloproteinases are released. Now MMPs are not there in the option. We are left with CGRP, substance P, human necrosis factor alpha, and interleukin 8. So option B and D can be the possible answers for this. B greater than D. This is something you'll have to remember about this. Okay. But anyways, you can definitely skip such unusual questions. There is no need to answer all the questions. Okay. Question number 12. The time after which bleeding stops in the vital pulp tissue after application of 2.5% sodium hypochlorite serves as a surrogate marker for, surrogate means indirect marker, depth of pulpal inflation, depth of bacterial invasion. See, whenever we do vital pulp therapy, okay, like we are planning to do, say, pulpotomy, we remove the infected or inflamed coronal pulp either partially or fully. Partial pulpotomy and full pulpotomy. So whenever we amputate the inflamed pulp, there would be bleeding, and we stop the bleeding by applying a cotton saturated with sodium hypochlorite on the severed pulp stump. We apply it for 10 to 15 minutes. If the bleeding stops, it means the pulp can be saved. It is a reversible form of pulpitis. If the bleeding does not stop, we can say it is a deep-seated inflammation and irreversible pulpitis. Here, what is happening? We are applying 2.5% sodium hypochlorite saturated cotton to the pulp stump for 10 to 15 minutes. Okay, so definitely it is a measure of depth of pulpal inflammation, whether the pulp inflammation is superficial and we can go for pulpotomy, or it is deep-seated and we have to go for pulpectomy. Okay, so pulpectomy or vital pulp therapy is decided basically how we are able to control the bleeding or not. So depth of pulpal inflammation, option A would be the answer. Question number 13. Incomplete caries removal in deep caries lesion case in which the tooth is asymptomatic or shows symptoms of reversible pulpitis is done to. Basically, it is asking you about indirect pulp capping. What is indirect pulp capping? It is a deep-seated carious lesion. Okay, so we remove a thin layer of caries above the pulp to prevent the mechanical exposure of pulp. Why it is done? Protect the dental tissues and prevent further damage to the pulp. True. Stainless steel hall technique? No. Conserve the sound tooth structure so that GICO composite restoration can be done? Definitely not. Pulpectomy? No. Option A, straightforward, simple answer. So that we place a medicament like calcium hydroxide or MTA and close the tooth so that due to stimulation of the the uh, pulp and there is differentiation of secondary odontoblasts in the area that result in formation of reparative or tertiary dentine that ward off, and subsequently if we have done a 2 visit IPC procedure we can excavate the remaining caries. Most of the time in the contemporary scenario, we do only a single visit IPC procedure. So basically, the principle and the motive remains the same, that we have to preserve the integrity of the pulp. Question number 14. Not true about heated composites. What are heated composites? I do not know that some of you must have seen in the market also that there is a device called syringe warmer for heating the composites before placement into the cavity. Okay, so heated composites are basically nothing but there's a regular composite syringe, and before placing the restoration out of it, we just warm or heat the composite in the range of 50 to 60 degrees Celsius. Okay, just heat it. It shows more shrinkage stress than unheated composites. It should definitely. A heated composite whose temperature is raised, it undergoes more degree of conversion. What is degree of conversion? The percentage of carbon-carbon single bond in the monomers that transfer to carbon-carbon double bond in the polymers. The greater the degree of conversion, greater would be the polymerization. Okay, it decreases the viscosity of composites. I am telling you what happens when heated composites are used. So the composite becomes more flowable. It adapts very well to the prepared tooth surface. Chances of void formation are reduced. Okay, it is more flowable. But the disadvantage that happens because the polymerization is increasing, and we all know that the major disadvantage of resin-based composites is the polymerization shrinkage. So more the polymerization, more would be the polymerization stress on the composites. So it shows more shrinkage stress than unheated composite is true. More polymerization stress would be there. It should be cooled to the room temperature before inserting in the mouth preparation. No. Then what is the point of heating the composite if we are cooling it? We are heating it and cooling it. So it just becomes of no use. It shows reduced curing time. Definitely, because they are more flexible, they are more flowable, the curing time is reduced. Better polymerization, we have already seen. Greater curing, we have already seen. And because greater degree of conversion. Yes. So option A, C, and D are correct for heated composite, and B is incorrect. They are not cooled. In the heated form only it is inserted inside the prepared tooth. Okay. So what would be the answer? Answer would be option B to the question. It is the answer over here. Question number 15. Which of the following is true for decreased flux intensity and increase in temperature? I am skipping this. This is not related to my subject and it is of, I would say, your DADH faculty would discuss it. Curie temperature is basically the temperature at which magnetism is lost. But let us not go into the details. Which of the following represents weak attractive intermolecular forces? This also is physical. Basic crystal structure of titanium, zirconium, and zinc. This also we can skip. Primary reason to doing bench curing of heat cure acrylic resin. This is a question from the subject of prosto. Question number 19. This is related to electronic apex locators. Which of the following causes inaccuracy in EAL measurement? What is EAL? Electronic apex locator. Pulp necrosis, periapical radiolucency, presence of separated instrument in the canal, and non-blunderbuss open apex canal. I think there should have been no problem in answering this. Electronic apex locators. The modern electronic apex locators, especially the third and the fourth generation ones, they work in all canal conditions, all tooth conditions, whether the tooth is dry, it is having necrotic pulp, blood, pus, whether there is a periapical lesion or not, whether there is a tooth fracture or not, whether there is tooth resorption or not. It works in all clinical conditions. Okay, so necrosis would not interfere with the EAL measurement. Periapical radiolucency also would not interfere. Okay, wrong options we have to rule out. Presence of separated instrument in the canal. This is a canal, suppose, and an instrument is separated, metallic instrument. When we are inserting a file, okay, that is connected to the electronic apex locator, and another is there with the lip clip over there. Okay, when the file contacts the separated file in the canal, it would form a premature circuit. Another metallic instrument, it would come okay into contact, so there would be a shorting of the circuit and it would give erroneous reading. So definitely this would interfere. Non-blunderbuss open apex canal has got no meaning. So electronic apex locators give you inaccurately reading whenever there are separated instrument in the canal. Option C would be the answer over here. Okay. Question number 20. Syringe and needle is the most common method of irrigation. Which of the following is not true? Syringe and needle is the most common method of irrigation. Which of the following is not true? 30 gauge side vented and closed and needle should be used. Yes, true. We usually prefer the 30 gauge needle, which is one of the smallest needle available. It guarantees the flow of irrigant in all areas of the canal. Now, this is not true. It cannot guarantee, no matter what gauge of needle, what irrigant we use, it is of no guarantee that it would reach in all the nook and corner of the root canal. Use of lower lock is mandatory. Yes, it prevents accidental disconnection between the hub and the syringe and spilling of the liquid on the patient's clothes and face. At times, especially, we have to be careful when we are using caustic materials like sodium hypochlorite. Okay, so we have to be very safe. So lower lock is a better option. A small volume syringe should be used for better handling and tactile cells. Definitely, if you're using a bigger syringe and you're trying to flush the root canal, it would be difficult manipulate and handle. So his option D is also correct. Option B would be the answer. No matter what irrigant, no matter what instrument we use, there is no guarantee that all areas of the root canal would be flushed adequately with the irrigant. Option B would be the answer. It is not true. Question number 21. What is responsible for the tissue dissolving property of sodium hypochlorite? Another straightforward question. Should have been no difficulty. Sodium chloride, definitely not there. Oxygen, no. Sodium hydroxide, no. Hypochlorous acid, yes. A unique property of sodium hypochlorite is that it undergoes ionization and forms hypochlorous acid. This hypochlorous acid is the oxidizing agent. Okay, so this is the answer over here. A straightforward question. Option D. Question 22. Internal transportation is internal transportation. Ledge formation, elbow formation, perforation, or blockage of the root canal. Internal transportation. Okay. These are related to the procedural errors in shaping of root canals. They are related to the procedural errors in the shaping of the root canals. Ledge formation occurs. This is the straight root canal like this due to inadvertent cleaning and shaping, non-judicious cleaning and shaping. There would be a obstruction in the root canal. This is known as ledge formation. Ledge is basically an extension. Ledge means a cliff-like thing. Due to using, I would say, large a non-curved instrument into the small canals, more of the dentine is removed from the outer wall and it becomes deposited. The dentinal chips become deposited inside the root canal, maybe blocking it completely, full ledge, partial ledge, incomplete ledge. But ledge is like a blockage. So this is the way internal transportation occurs. So answer would be A. What is elbow formation? Elbow formation means you have gone. I would draw another diagram for this schematic diagram. This is the original path of the root canal. Okay, due to inadvertent cleaning and shaping, you have removed more of dentine and made the canal like this. Okay, the path of the canal has changed. This is known as elbow formation. Here there is a slight extension. Elbow is like this. Okay, so you can see the root canal was supposed to be like this. Root canal was supposed to go like this, but in the outer aspect, it has become like this. So this would be the final shape of the root canal, marked with green. This is known as elbow formation. Now, there is no transportation. It is following its curvature only. There is a slight bulge on the outer curvature. This is known as elbow formation. So internal transportation is basically ledge. Option A. Question 23. Match the following. Single cone, lateral compaction, warm vertical compaction, and gatta core. A1, B2, C. What is gatta core? Plastic carrier coated with alpha phase of gatta parcha. Okay. Single cone obturation methods. I'll have to check whatever is there. System is hung. Mhm. Okay. It is hanged. Okay. Sorry for the technical glitch. I think it is okay now. Technology is good and bad at the same time. There's no substitute for physical lectures, isn't it? Anyways, coming over to the. So I would say basically they are arranged in the same order. The single cone, I do not know. We use matching with the corresponding nickel titanium instrument with which we have prepared the canal. Lateral compaction. Cold lateral compaction is a cold obturation technique. B2. Warm vertical compaction. Thermoplasticized apical seal is obtained, definitely. In the warm vertical compaction, we apply a heated plugger on the master cone of Gattaparcha. So the Gattaparcha melts and it flows apically and laterally. So there is a thermoplasticized apical seal basically. And what is Gatta core? Gatta core is a plastic carrier that is coated with carrier based Gattaparcha, basically alpha phase Gattaparcha. So A1, B2, C3, and D4. Option A would be the answer. They are already matched. Okay. Question number 24. The steps of WVC. WVC means warm vertical compaction. Warm vertical compaction. The steps of warm vertical compaction are cleaning and shaping of the root canal, sealer placement, downpack, and backfill. All the steps are there. I do not know what options were given over there. Warm vertical compaction. This is a prepared root canal. We select a master cone of Gattaparcha. This master cone is seated 0.52 millimeter short of working length. This is your master cone. In the sealer coated root canal, we place the master cone that is pre-selected, which is such that it is 0.5 to 2 millimeter short of the working length. Then we take a heated plugger, can be a finger or hand plugger. This is heated plugger. And apply apical pressure so the master cone melts and flows apically and laterally. Okay. And the remaining of the canal, the upper portion of the root canal, is filled with thermoplasticized Gattaparcha. which is known as backfilling. Downpack means this master cone. This is called downpack. This is backfilling with thermoplasticized kattapacha. Cleaning and shaping is initially dull, and sealer placement is always there. So all the four are the steps in warm vertical compaction. Question number 25. The patient reports with severe pain 24 hours after obturation. Okay. Which of the following cannot be the reason? Cannot be the reason. High occlusal contacts. You must have noticed that initially in your UG years, when you have done amalgam restoration or any other restoration, if the patient is having high points, there would be development of pain couple of hours after the restoration. Okay, because of occlusal prematurities. So definitely high occlusal contact can be the reason for development of pain within 24 hours. Coronal leakage. It can cause failure of the root canal and pain, but not within 24 hours. It would take 3 to 6 months for the coronal leakage to be of any clinical effect. So definitely not. The periapical extrusion of debris, definitely. Anything which encroaches the PDL would cause immediate pain because PDL has abundant A beta nerve fibers. A beta nerve fibers are the proprioceptors. We check always tenderness on percussion. So whenever something is encroaching the PDL, okay, it would stimulate the beta nerve fibers and there would be pain. Over obturation, pain. All A, C, and D can cause pain within 24 hours, but not coronal leakage. Option B would be the answer. Okay. Coronal leakage would cause pain, but at least 3 to 6 months later. Question number 26. Which crown will cause the least wear of the opposing natural enamels? Although it is not directly related to the subject of cons and endo, but definitely we can answer this. Monolithic zirconia, highly glazed zirconia. Zirconia is a very tough ceramic. It would always cause severe wearing. Monolith. If I have to make a sequence out of the options given, then least wear, or we can say tooth wear, ultra low fusing ceramics, less than lithium disilicate, less than option B, that is glazed zirconia, less than monolithic zirconia. So option D, C, B, A. Highest wear, least wear. Answer would be option number D. Okay. Question number 27. Which is not a technique of CAD-CAM? CAD-CAM is computer-aided designing and computer-aided machining, selective laser sintering, stereolithography, hot pressing, and fluid deposition modeling. Definitely hot pressing. Option C would be the answer. All other are techniques that are computer controlled. Okay, they are the modern methods for fabrication of dental prosthesis. Hot pressing is simply the molten ceramic is subjected to pressing especially used for the hot pressed glass ceramics like IPS, Empress, etc. Okay, pressable glass ceramics. Question number 28. Not a feature of camera. What is camera? Camera is a method of caries assessment and management by risk assessment. Okay, so caries management by risk assessment. So, what is not a feature of camera? Caries assessment, risk stratification, preventive and protective factors. Caries assessment is done. Risk assessment is also done. Risk stratification is not done. And preventive and protective factors we talk about. So, option C would be the answer. Okay. Question number 29. Thickness of MTA plug-in epoxification is in the range of 4 to 5 millimeters. Okay, single best answer would be 4 millimeter. If we look at the options, 3 to 5 millimeters, greater than 8 millimeter, 5 to 7, less than 3 millimeter, definitely option A would be the answer. If for immature pulpless teeth, we make an apical. For immature pulpless teeth, we make an apical plug of MTA that is 4 to 5 millimeter thick. Usually it is 4 millimeter thick. So if you get a question that has got single options 2, 3, 4, 5, stick to 4 millimeter. The range is 4 to 5 millimeter, or definitely it can be 3 to 5 millimeter also according to options given over here. Option A would be the answer. Question number 30. Air abrasive polishing uses which material? Air abrasion or air polishing. Okay, it uses sodium bicarbonate. That is sodium bicarbonate. If it is about, if polishing is not given, it is simply air abrasion, which is also called sono abrasion. Okay, answer would be aluminum oxide particles or alumina particles that are used for kinetic cavity preparation. Here it is asking you about polishing. Answer would be sodium bicarbonate. Option A. Okay, aluminum oxide particles mostly used are 25 micron wide. These also have been asked in several examinations. So do not get confused between polishing, that is sodium bicarbonate, and abrasion with aluminum oxide or alumina particles. They are called alumina particles. Question 31. The temperature sensitivity of dental pulp is due to which of the following nerve fibers? I think there should be no difficulty in answering them. A delta, C, AB, and sympathetic nerve. Sensitivity. It is asking you about sensory nerve fibers. The pulp has got two types of sensory nerve fibers, A delta and C. Okay. A delta sense the pain, temperature, and touch. C fibers, sensation of pain. So temperature sensitivity. You are taking a hot coffee, you are taking cold ice cream, you feel immediate pain. That sensitivity is mediated through A delta nerve fibers. Option A would be the answer, isn't it? Question number 32. The statement is the plugger in cold lateral compaction should be placed within 1 to 2 millimeter of the working length. Technically speaking, it is not the correct statement because it should be spreader. For cold lateral compaction, we use plugger for warm vertical compaction. If I go with the language that is over there and the words that have been used, Okay, I do not know it is correct or not, 100%. And hand spreader produces less stress on the root than finger spreader. What is a hand spreader? There is a handle, and then there is a spreader like this. On the other hand, we have got a spreader like this, which is a finger spreader. So this is finger spreader. This is hand spreader. This is preferred and this is not preferred because it generates more force and chances of root fracture are there. So hand spreader produces less stress on the root than finger spreader is incorrect. So both are correct, both are false. A is correct and B is false. A is false and B is correct. If plugger was there in the options, okay? If this word plugger was there, this is also incorrect. It is definitely placed 1 to 2 millimeter short of the working length. True. Whether it is a spreader is placed 1 to 2 millimeter short of the working length, but not plugger. In cold lateral compaction, we use a spreader. So both options would be false. If it was a spreader, then A is correct and B is false. I hope you understand what I mean to say. Okay. If I have to go with the strict technicality of the word, and it is a definitely scientific thing, so we cannot just confuse and interchange spreader with plugger. We cannot do warm vertical compaction with a spreader that is a pointed instrument. Okay, so for cold lateral compaction, definitely we select a spreader that is 1 to 2 millimeter short of the working length. Question 33. ESR is differentiated from internal resorption. What is ESR? External cervical resorption. From internal resorption by in the parallax radiograph, ECR lesion moves with the tube shift, whereas the internal resorption lesion stays with the center with the canal. Definitely, there's a tooth with a lesion like this, and there is a tooth with a lesion like this. This is a case of internal root resorption. This is a case of external cervical resorption. The canal outline is visible through the defect. And since the lesion is superficial, when we move the X-ray cone, the lesion would move with respect to the canal. Here, it is just an extension of the root canal. No canal outline is visible through the lesion. So this lesion remains fixed in position no matter which angle we expose the X-ray. So it would not follow the slope rule. It would follow the slope rule. Option 1 is correct. Loss of lamina dura, pulpal outline is intact, clear symmetrical radiolucency. No. These are not clear-cut distinguishing features. Option A is the most predictable feature. Another thing I have told you is important to remember, that outline of the root canal is visible in external cervical resorption, whereas on the radiograph, the canal outline is not visible through the defect in internal root resorption. Coming over to question number 34. Good Lord, there were so many questions. Okay. Trauma case, tooth is mobile but not disclosed. Subluxation, concussion, lateral luxation. Tooth mobile but not disclosed. I do not know. This is incomplete question. I do not know what is being asked. Whether it was image-based question or not. Let us skip this. Question 35. According to the law of symmetry, the law of equidistance is applicable to all teeth except This is a straightforward question. If you have gone through the class notes, you must be remembering that they are based on Kressner and Renko's principles. Kressner and Renko's principles and law of symmetry 1 and 2. They are not followed by maxillary molars. Answer would be A. Okay. Someone has asked me that if the tooth is elevated in the socket, what would be the diagnosis? The tooth can be elevated in the socket. One of the simplest and most common reason is development of a periapical abscess in the tooth. Okay. In most of the situations, it is a acute periapical abscess that causes tooth elevated in the socket. Slight extrusion or elevation of the tooth occurs in the socket due to periapical abscess formation. Question number 36. After 1 year of root canal treatment failed, it was diagnosed with missed MB2 canal. What should be the treatment plan? This is a very frequent clinical situation that most of the time when first molars are treated, maxillary first molars, MB2 can be skipped and a well-treated root canal fails because of missed MB2. So what is the treatment plan? Redo root canal, non-surgical RCT? Yes. Antibiotics and analgesics, they are just symptomatic. They are not the treatment. They can control an acute episode of pain, but they do not treat the tooth. Episectomy, not required. Extraction, not required. Simple question, straight answer. Option A. Okay. Now this is something interesting that has come. Slot in the titanium trauma splint is of which shape? ETS. This is very interesting, okay? I do not know whether you have gone through these or not. Titanium trauma splint is basically a ready-made splint, okay, of titanium. It is something like this. A spool of titanium is available that is cut into the desired length, and it's used for physiological splinting of the teeth in cases of trauma. We know that splinting is required in many cases of trauma, whether it is lateral luxation, subluxation, extrusion, intrusion, or avulsion. So it is asking you what is the shape of the slot. The shape of the slot is oval. That is something about observation. Okay. In the visuals of the cons and endo that I have shown in my classes, titanium trauma splint is there, but definitely that observation is required that we identify the shape of the slot. But anyways, very interesting question. Option B would be the answer to it. Titanium trauma splint. Again, I have received a question that can a differentiation between pulpal abscess and periapical granuloma made clinically? Answer would be no. In fact, radiographically also in majority of the cases, we cannot distinguish abscess from granuloma. Only histology can examine and tell you whether it is a clear-cut case of abscess or granuloma. Clinically, not at all possible. Question 38. Dental material, not my domain. Okay, dental stone model plaster would be taken care of by DADH faculty. This is all. These were the questions. I would say in all that was a very interesting question paper if I talk about my subject, and majority of the questions were knowledge based and straightforward with a few exception, one or two questions. They can be safely skipped. Okay. Anyways, thank you so much for being connected with me. That is all for tonight. Happy reading, everyone. Best wishes for your future endeavors. Thank you so much.